just going to take you through the model that I like to use as far as joint assessment is concerned. Now, I like models. These things stick in my head. Models are really good when you walk into your joint assessment exam or you walk into your massage exam and you're confronted by the dinosaur that is your lecturer or your teacher, and your mind goes blank and then you can't remember anything about the ankle. But you can remember the assessment routine, which allows you then to muddle through the process of assessment and at least get a pass. Your assessment starts off with your subjective assessment, and the subjective assessment is basically where you're asking your clients questions regarding their injury. I'll do a video of this at some point in the future. Objective assessment, which is the second stage. Now, before you get to your objective, once you've taken your case history, you need to have at least 2 working hypotheses, so things that you think it could be. This is really important because you're going to get a shitload of information coming through when you start to do your assessment, and unless you've got something that you're assessing for, it makes it almost impossible to work out what's causing your tissue symptoms. The first part of your objective assessment is called your observation. Now, this starts informally in the waiting room when you go and pick up your clients, watching how they walk, watching how their arms swing, watching how they move, and then it proceeds into more of a formal observation when they're undressed, standing in front of you in that awkward anatomical position that you get people to adopt. During the observation, we're looking for things like bruising, swelling, redness, signs of acute inflammation if you're dealing with an acute injury, or if we're looking at more chronic injuries, we might be looking at some of the sort of postural imbalances, the slight twists that take place in the spine, the attitude of the limbs. These things might give us some ideas as to the predisposing factors, the things that are likely to cause your patient's problem. Now, be careful with this because there's a lot of people that jump to conclusions when they're doing their observation. Your brain is a machine that likes to find connections. Think about that word game when they put the first letter of a word and the last letter of a word and your brain sees the whole word. That's what you try and do during observation. You start to join the dots. Don't make any assumptions at this point because you've not put your hands on, you've not moved the joints. Simply see what's in front, make a note of it, and then move on to the next stage. The next stage is palpation. Now, I've put an asterisk next to palpation because sometimes I leave palpation until after we've done resisted movements, and that's due to the tissue irritability. And what do we mean by tissue irritability? Essentially, if your symptoms, let's say you've got back pain, the minute you sit down, your back pain kicks in. And then you stand up to try and relieve your back pain, and it takes an hour before those symptoms have relieved. On the other hand, let's say you sit down, and after an hour, your back pain comes on. As soon as you stand up, your back pain goes again. The first example is a tissue that's highly irritable. The second example is a tissue that's less irritable. In the second case, I'd palpate after the observation. In the first case, when the tissue is highly irritable, I'd palpate after we've done resisted movements. That way you're not stirring up the tissues and you're not likely to get false positives when you start to move into the other parts of your assessment. Next stage is joint clearing. Now, joint clearing is basically making sure that the symptoms that your patient has got are coming from the joint that they're complaining of. Sometimes pain is referred. So if it's the joint above, pain can be referred via the nerves. And if it's the joint below, pain can be referred by biomechanical changes, tight muscles, stiff joints. So your joint clearing, we clear the joint above and we clear the joint below. If there's no pain in the joint where they're complaining of symptoms when you move the joint above or below, that suggests that you're clear to move on to actually assessing the joint in question. If you get symptoms when you're moving the joint above, or if you're moving you get symptoms when you're moving the joint below, then you might need to consider that you need to assess the joint above rather than the joint where they're complaining of symptoms. Next stage is active range of movement. Now, active range of movement is testing the contractile structures. What do we mean by contractile structures? We mean muscles and tendons. Now there is some contention in the literature as to whether a tendon is a contractile structure or not. I believe it is. Your lecturers, other therapists might believe it's not. Have a read, make your own opinion, and then make sure that's consistent with what you're assessing. Now, active range of movements, we're looking at the range of movement of the joints, we're looking at the quality of that movement, and we're looking at any pain through range. Now, what do I mean by quality of movement? So when a muscle's injured, you'll often find there'll be some juddering, there'll be some inability to be able to control the movement, and that suggests there's some muscle weakness or maybe some neurological problem that's starting to affect the way that the joint's moving. So those three things, range of movements, compare that to the other side, because not everybody falls into these norms that you'll see in the anatomy textbooks. So there you've got an uninjured limb compared to the injured limb to work out how far away from being normal that is. Passive range of movements, this is testing the non-contractile structures, and by non-contractile we mean ligaments, we mean the joint capsule, we're looking at the joint surfaces. So for those of you that have got clicking and grinding and popping that take place in your joint, a term that's described as crepitus, this suggests that you've got wear and tear on the articulating surfaces, or the joint is in a position where it's not running smoothly. Now, the same as we did for active, your passive range of movements is looking for the range of movements, the quality of movements, and again any pain through range. But unlike the active assessment, the active range of movement assessment, here we're also looking for end feels. Now, end feels determine the state of those non-contractile structures. So when we get to the end of range, every joint has got a specific type of end feel. If we take the elbow joint, for example, when we get to end range elbow flexion, this is described as a soft end feel. So the soft tissues of my forearm and the soft tissues of my upper arm oppose each other. So that's described as a soft end feel. Now, in the elbow joint, when we go into extension, there's two bony surfaces contacting each other. Those two bony surfaces, the olecranon process, the olecranon fossa, contact each other, and that creates a hard end feel. The final normal type of end feel is what we describe as springy or elastic. If we take the elbow joint again, this is supination, this is pronation, and again, if you take your supination to the end range of movements, you'll feel there's an elastic recoil there, and that's what we describe as springy or elastic. Next stage is is your resisted movements. Now, at this point, you might find that you've got some discrepancy between, you've got some pain on active movements, you've got some pain on passive movements, and you're not sure whether it's a contractile tissue or a non-contractile tissue. This is where you're going to work out whether it's contractile or not. Resisted movements tend to be in the mid-range of movements, so where the muscle's strongest, and we tend to use the Oxford scale to grade those muscle contractions as to whether they're normal or not. Final part of your assessment is moving on to your special tests, and this will be the subject of a couple of different videos where we'll talk about special tests for each region. This includes functional movements.